So thank you very much. It is, for me, truly inspiring to be here. It's not often you experience a community, nonetheless an entire island, that wants to change. For the past 15 years, I've been working, trying to change the Norwegian mental health care system, and it's not easy. It's a struggle. Change is often challenging and painful and difficult and full of conflict. And the fact that you're inviting to change is admirable. And hearing everything I have heard today, I'm sure you will be able to do it. And I think open dialogue can work as a framework for incorporating everything so far we've heard today. So I think earlier today we said that we had all been touched by mental health issues at some point in our lives, either ourselves or family members or friends or colleagues. I'm wondering what kind of help, what kind of support you received at that time, if you were satisfied with that help. And if not, I want you to just close your eyes and for 15 seconds, imagine the perfect mental health care system. How would you like to be met, supported in a crisis? Okay, thank you. Hopefully, I will mention some of the things you thought about, and if not, please get in touch with me afterwards and let me know what I left out. But today, there are a lot of people that are simply surviving. We've heard this before, but have you done the math? Upwards of 15,000 people on this island alone experience some kind of mental health issue every single year. Generally, 1 in 7 of those will receive some type of help. So they're going it alone. 10,000 of your islanders every single year are not getting the help they need. They're merely surviving. They're not being met with the love and the care they need. They're not being met with the open, direct conversations that we've heard about earlier today. Think about if someone said that there are 10,000 of you with diabetes and you're not getting treated. Just the immensity of the problem, I think sometimes we don't take seriously. We do need change. We need drastic change, and we need it now. But it doesn't have to be hard or difficult. A lot of times what people want is more talk and less treatment. They want to be listened to. It's sometimes that simple. They want to be cared for instead of cured of some illness they supposedly have. And instead of a diagnosis, maybe they just want a dialogue. Someone to talk to, someone that sees them and can respond to them. So Jaakko Seikkula, the Finnish psychologist who's developed the open dialogue approach, says, you know what, we've had enough of different psychotherapeutic approaches. What we need is a different way of being. It's not enough to say, let's do CBT or early intervention. We need to change as individuals. The wonderful thing about dialogism is I get to practice it every single day. I don't go home to my wife and say, you know what, you've got this problem, but I've got some CBT for you. Here, well, just a half an hour and you'll be fine. I go home and I say, sweetheart, can we talk? And when my 17-year-old daughter is having issues and problems, I say, should we talk? And in 99% of the situations when someone is experiencing a crisis, what they need is someone to talk to. And so we can all become dialogical. We can all go home today and start a new dialogue. But it started a long, long time ago. Has anybody heard of social networks? Social network therapy. Does anybody know any social network therapists? No. They hardly even exist. But 50 years ago, the idea of social network therapy developed. And it's very simple. You bring everybody together at the same place, at the same time, and you get them to talk. So you have the psychiatrist and the GP and the grandma and the uncle and the teacher and the colleague and the coach and grandma. And you say, how can we help? So it's not that difficult. Having a social model, being trained in group therapy and family therapy and community therapy, many of those things that we've talked about today. And it works. It's unifying, short, and powerful. And yet we don't have it. 1960s, 1970s, 1980s, 1990s. It's still not there. I don't think they had the research. Now we do. We know this is evidence-based. We just talked about suicide. We can reduce suicide by 90% just by involving the family. And is it expensive? No, we save money. £4,000 on average in the course of 3 years by simply involving the family. The time for change is now. People in Tornio, it's not exactly an island, but it could be culturally, politically. These small places like this island, like Tornio in Finland, nobody cares about them, so they're allowed to do whatever they want. They're allowed to innovate, which is a unique opportunity. And so they did that. They started with network therapy, and they started a continual process of improvement. So they involved carers and users, and they said, how can we be better? And they started to do research on it, and now it is the most researched mental health care system in the world. And one of the things they found out was education is everything. So they started to teach every single person in the system family therapy. And they now have the best educated mental health care service in the world. That's what it takes. And they get great results. Some people say the best results in the world. Compare open dialogue to treatment as usual. 82% after 2 years had mild or no symptoms. 74% had returned to work or study. The average for the UK is 9%. So we know it works in Tornio anyway. And then it came to Valdres, Norway, another kind of cultural island in the mountains of central Norway where I was working. And their motto was, it's only natural. And everything they did said, let's get back to what we were as a local small community taking care of each other. Let's not complicate things. Let's be human together. Let's talk. Let's care for each other the way we have done for 1,000, 2,000, 3,000, 4,000 years. And now we're seeing a number of indigenous approaches to mental health care, where the village comes together, where people come together to talk and help each other with very human problems, very existential. It's hard to live sometimes. It's painful. We don't know why. Our relationships are difficult. That is very human. So if we can humanize mental health care, we can achieve a lot. So we evaluated our program after 10 years, and we got great results. There was more active patient involvement, greater understanding regarding mental illness, enhanced communication, improved coping skills, increased openness with feelings, deeper insight, and improved relationships. It works. Just bringing together people works. And it's spreading. We have a large European network. There's things going on in Poland, in Germany, in Italy. There's a large open dialogue conference now in Turin, Italy, where I should be, but I wanted to be with you guys, so I'm here. And the word is spreading, and more people are seeing that this is a way forward. In the United States, University of Massachusetts Medical School, one of the best medical schools in the United States, they're working to implement open dialogue. New York City 5 years ago got a grant for $17 million to implement open dialogue in the Bronx, Brooklyn, Manhattan, Queens. If they can do it there, you can do it here. And they're getting great results. And then I was approached by a wonderful psychiatrist, Russell Razak, who's at Northeast London Foundation Trust a few years ago. And he says, Mark, we want to change the NHS. And I said, I'm in. And in the period of very few years, 4 years ago, we have been granted £2.3 million to run a 5-year study of open dialogue, peer-supported open dialogue, because we need the evidence. We need the legitimacy. We need to go to the people that are making policy decisions and say, this is the way we want to do it. And we've also developed a training, because training is everything, getting people to work. So we've got a year-long training to develop these skills. Russell, I, and a family therapist, Val Jackson. It's a wonderful experience. We sometimes joke about it and sometimes we cry about it. It's all about becoming more human. And that's what it takes. It's that simple and it's that easy. I don't think this psychiatrist can help you at all. Most psychiatrists are completely worthless. But Greg I would go to with my life. And that's the difference. It's human relationships. And it's giving people a year to work on developing that and reflecting on that and how they, as individuals, can help people. This is 1 week ago today, we had graduation. We had people from France, from Israel, from the Netherlands, from Germany, from the UK. It was a great, great experience. I don't know if there's a big guy in the back waving with a big beard. Does anybody recognize him? That's Matthew Whedon, the co-owner of the Belarus. So now you have a local boy who is a peer-supported open dialogue trainer. So we have one. So now we just have to get the rest of you. But that's a start. So what is actually open dialogue? There's some clinical aspects, the poetics, and there's some organizational aspects, and you need both. They need to support each other. Dialogism. One of the first principles we teach our students is you will never have a conversation about one of your patients ever again without them being present. Common courtesy, right? But it happens all the time. And not everybody agrees. But there is something very simple about when the psychologist and the psychiatrist have an open, honest discussion about their own inner thoughts, about how they're understanding the situation in front of the patient and their parents and their colleagues and their friends. And that is openness. That is transparency. So that's what we need to do. Nothing about them without them. And it's simply a matter of responding to the stress, distress, the feelings, the emotions, the pain that they're having. Just simply being present for them. Which creates a lot of uncertainty and anxiety with most professionals. They like to have control. Does anybody not like to have control? Not many. So teaching people to deal with that uncertainty, the complexity of recovery, the emotions that come up, that's not easy. And we try to respond immediately. In a crisis is also an opportunity. So we're there. If you get a heart attack, we don't say, yeah, okay, call me back next week and we'll see what we can do for you. We don't do that. We say, your crisis is serious. We'll be there within 24 hours. And we have one point of contact. That means they don't get sent between different telephones and people and organizations and teams. They pick up the phone, they make a phone call, and we say, you've come to the right place. That's what I would want. And it's radically person-driven. We have network meetings whenever, wherever, with whoever. It's your life, we will be there for you. And we don't have an agenda. We come in and say, how do you like to use our time? We're here to help you. You decide. If it's housing, we'll talk about housing. If it's getting a job, we'll talk about getting a job. If it's self-harming, we'll talk about self-harming. Whatever you are concerned with, that's what we talk about. When I came to England, I was amazed by how many teams you have in England. They've got crisis teams, and they've got community support teams, and they've got home resolution teams, and they've got early psychosis teams. The research says that if you have a psychotic episode, within the first year, you will meet over 100 professionals. There's no chance of creating relationships there. So psychological continuity. The thing is that's going to help us is relationships, people that we trust with our lives, because that's what it's all about. And a social network perspective, bringing everybody together. You take care of the social, the rest will take care of itself. And so as part of the English project, we've tried to develop open dialogue, which again was developed in the early 80s, and looking at current trends within mental health care. So we think of POD as a value-based practice. So if you are part of an organization, do you know what values are important for that organization? Most people don't. But in our teams, that's important. So actually being open and authentic as who you are as a person, and cultivating your ability to care and feel compassion for another person is something that we work on. And we use mindfulness to do it. You've heard a lot about mindfulness. You'll hear about mindfulness tomorrow. But we ask every single student to develop a daily mindfulness practice so that they can cultivate insight into themselves, self-care, and compassion for others. And we develop relational skills, and it's actually quite easy. This is evidence-based. The only thing you have to do is be flexible, honest, respectful, trustworthy, confident, warm, interested, open, explorative, reflective, noting past therapy success, interpreting accurately, facilitating the expression of affect, and attending to the patient's experience, and you're done. How often do you practice this? It's time on task. This is what helps. So we spend a year practicing this, reflecting on what would this mean in our practice. How could we support each other in doing this? Because this is what's going to help. And yet in most healthcare systems, you never have the time or the opportunity to practice this with your colleagues. And we talked earlier about social determinants, about inequalities in mental health care. Mental health is a political issue, and so we need to talk politics. We need to be activists. We need to get out of the clinic and create social-wide change. That's the only solution. And as we were talking about before, ACEs, trauma-informed care. Realizing how pervasive trauma really is and how we deal with that is important. And peer support. Has anyone read the mental health and well-being report that came out like 3 or 4 days ago? Good. Everybody's up to date. I have. And it's wonderful because they mentioned peer support. So I think if there's one thing we can work on, it's including people with lived experience in our practice. They know what it's like. They've been there. They've been to hell and back. I haven't. I have no idea. They have a unique expertise, a unique knowledge, a very much embodied understanding of what it means to be a receiver of mental health care. So in our teams, there is always a peer, always a person that has lived experience. And so what are our roles, those of you who are professionals? We need to get away from that we're experts, that we will solve people's problems. What we should be doing is helping the helpers and supporting the supporters, creating sustainable change within people's lives so that they don't need us anymore. And we certainly don't need Greg. So what do we need to do? How do we go from surviving to thriving? I think it's fairly simple, but it's not easy. We need to create caring communities. We need to go home today and every day and practice being dialogical, practice being compassionate in all our relationships, and doing everything we can to create caring, compassionate communities. I wish you luck with that. Thank you.